My colleagues, I wanted to give you a very important advice. Uh, According to the feedback of January candidates, post-operative and post-transplantation cases are included in the exam. They didn't present a very strange or a very complicated finding or complication, but try to read about it as much as possible. Uh, Dr. Ali, this is 9 years old female patient presented with severe abdominal pain.
Okay, I have been presented with multiple axial CT images of IV contrast for a lady with severe abdominal pain. Sir, can you scroll for me, please?
Dr. Ali, did you set 5 minute
Yeah, yeah.
timing?
Yes, I
Okay,
did.
go on,
Yeah.
go.
So can you scroll for me, sir? Yes. This is axial images, abdomen CT scan with IV contrast for an adult female patient with history of severe abdominal pain. I will, in my routine practice, I will scroll through the last cut, then I will comment on my finding. First of all, I noticed that there is hypoperfusion of the left kidney. The left kidney appears also enlarged in size in comparison with the right kidney. Regarding the aorta, I can see that there is extravasation, hyperdense extravasation of contrast seen at multiple points surrounding the abdominal aorta. This is seen in the suprarenal abdominal aorta. I will also scroll down to see if there is any associated abnormality. I'm now within the pelvis. I cannot see any significant abnormality. Okay. I can see that there is large air fluid level noted within the stomach. I can see that the liver appears enlarged, mostly representing hepatomegaly, no focal splenic lesion, and the right kidney, also spleen. I can see that where there is wedge-shaped hypodensity noted in its posterior lateral aspect, most likely representing splenic infarction. In my routine practice, I want to see this in the coronal and sagittal images.
What's your final diagnosis?
And my final diagnosis uh, appearances are mostly those of aortic rupture plus occlusion of the left main renal artery, resulting in left renal infarction. And so I can see that there is the splenic infarction also.
Okay, have another look, please. Is
Mhm.
this rupture? Are you
No,
sure
no,
this is rupture? Look,
no,
please.
no, it is not rupture. I think there is aneurysmal sac. So this could be due to abdominal aortic aneurysm, and I can see that there is, which is contrast extravasation or penetrating ulcer, which could representing signs of impending rupture.
No, see, this is irregular dilatation. Look at the wall, please. And did could you tell me the age of this patient? I mentioned in the beginning. How old this
Yes,
patient?
um, I missed the part of the history, but I think it's 70, something like this.
No, this is 9 years old female patient.
Ah,
So what
9 years.
do you think? Nine
This could
years old, and you have aortic, see, aortic dilatation. irregular wall, and multiple infarction. What does it mean for you?
I'm thinking context of vasculitis.
Okay. What
That
else?
uh, there is syndrome which is called mid-aortic syndrome.
No, 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 no. Don't worry about it. Mid-aortic
Okay,
syndrome. See, in mid-aortic syndrome, you will see the aorta like this,
it
completely
will be small,
visualized.
small in caliber.
Yeah. What else? Look at the nature of this dilatation. Irregular, and the wall of the aorta itself is thickened. What does it mean?
Could be due to aneurysm.
Okay, this is aneurysm. Okay, this aneurysm. What type of
Yes.
aneurysm? What type of
Ah,
aneurysm do you know?
there, there is fusiform aneurysm, saccular aneurysm, mycotic aneurysm, and inflammatory aneurysm.
Yeah, which type do you think this aneurysm? Look, this is the delay. Which type?
I think this could be mycotic aneurysm
Why?
because it is associated with infection within the renal. I think there is, I saw some abnormality within the renal. Yeah, here.
Okay,
It
so
could
so
be,
you means it may be pyelonephritis, okay,
yeah.
complicated by
Yeah.
aortic aneurysm. Is
Yes.
this is this a logic scenario?
No, the logic scenario,
What else?
it
Yeah.
uh, it could be due to splenic, um, uh, vertebral abscess or collection, like spondylolischitis or something that
Okay.
complicated by
In
mycosis.
9 years old, doctor, try to connect the finding with the age with the contribution. In 9 years old, what is the most common cause of infection like this, mycotic aneurysm like this?
It could be due to
Okay.
abscess
What
collection.
else? What else?
Uh, I don't recall.
Okay. Time is up. I think we passed the 5 minutes.
Yes.
Okay. Thank you, Dr. Ali. This is sure a mycotic aneurysm. Why? Uh, See, my colleagues, don't forget the history. When the examiner is telling you something, really have the answer in the first few seconds. Have the answer in the mouth of the examiner when he guide you. What happened here, my colleague? This is 9 years old female patient, and then you scrolling, you find a lesion like this. It may be focal lesion, maybe. Okay, go down. Also, also the left kidney is totally abnormal. Multiple, for example, focal lesion, but no expansion or no mass effect. So this is almost non-enhanced areas. So I'm talking like a candidate under stress in a viva for his second, third, fourth time, and he's totally in very bad situation. Okay, he must talk himself like this. Okay, these lesions. Oh, this is not lesions. This is hypovasculature. Oh no, this is ischemia. So multiple ischemia in the ischemic areas in the kidney and in the spleen in young age. So there are some sort of embolic showering. Very nice. Okay, then oh, what happened for the aorta? This is rupture. It may be rupture, but has another look. No, it has another look. Come up. This is the lumen. Go down again. The lumen is irregularly dilated, surrounded by thick and faintly enhanced wall. This is the secret of this case. The wall of the aorta is thick and faintly enhanced. Okay? And what happened? This is the aorta itself, my colleague. This is the aorta itself. This is not extravasation. Okay? And don't ask the examiner for any other plans uh, if he give Excel, especially in cases very clear like this. Don't ask why he will tell you this is very obvious. Anyway, so I'm dealing with three entity: ischemic spleen, ischemic kidney, and mycotic aneurysm. So almost there are one main source of this pathology. Go down, nothing else. Go up. So this patient suffering from septic emboli. So I'm dealing with 9 years old female patient with septic emboli affecting aorta, spleen, and kidney. I should enumerate for the examiner the most common causes in this age group. Okay. Number one, infective endocarditis. Number one. Why? Because this patient almost is not a drug abuser, almost may be immunocompromised, but I didn't have any signs of immunocompromisation in this examination. Even here, you can't see, frankly, honestly, there are no obvious vegetation within the heart. I'm trying to search it to examine the heart. There are, for me at least, there are no any obvious vegetations. And I can't tell anything about that apart from it looks like mildly dilated or mildly enlarged. But at least from our knowledge, from our differential diagnosis, infective endocarditis. Number two, okay, maybe TB, but look at the lung, even in the bone window, it is very clear. Okay, if you want to ask the examiner, I wanted to change the chest to lung window. Okay, if there are any finding, he will tell you, okay, but almost he will tell you, don't worry about it. Okay, my colleagues, this is a mycotic aneurysm, mycotic aortic aneurysm. Okay, very important. One of our colleagues has been presented with one mycotic aneurysm in the exam, and the examiner gave him a very confusing images. But thanks God, he's our candidate can answer the case very well. Okay, my colleagues, again and again, mycotic aortic aneurysms. Here they ask for MRI. Why MRI? Look at the diffusion here. Look what happened. Marked restriction. Why? Because this is cytotoxic inflammation. This is inflammatory changes in the wall of the aorta. Cytotoxic inflammation. So there are a restricted diffusion. And besides the finding in the spleen and in core. Is it clear? I think it is clear.
Yes, it is
Uh,
clear.
yeah, one question somebody asked, should I ask for MRI or this CT is satisfactory? At least give some difference. In the exam, the examiner are examining your attitude. If you presented in the NHS with this case, what's come in your mind? One, two, three. Very great. It is very logic. Number two, what will you do? What is your management? What is the next step? It is not uh, requested from all of you to answer all the cases exactly. No, the most important to give a logic suitable scenario. What is the management of mycotic aneurysm? What, Dr. Candidate one? What is the next step or management of mycotic aneurysms?
First, I think wide spectrum IV antibiotics.
Thank
Then,
you. Thank you. This is, if I am examiner, a half of the mark I will give for the management. Why? If you told me, doctor, immediately you will transfer to interventional, it's a very big disaster because all of these are very very friable tissue. Okay, very important. Wide spectrum of antibiotic first. Thank you, doctor, so much. Next candidate. Next
Candidate,
candidate,
Good
ready?
afternoon, sir.
yeah.
Yeah.
Ye-
Dr. Ali, please, I
Yes,
didn't hear the 5 minute time during the first candidate examination.
Yes, it was in the middle of discussion. So
Okay,
from I will let you know.
okay, thank you. Candidate two, doctor, this is 50-year-old male patient presented with left upper limb weakness, and the patient has dysphagia he undergoing cervical after he undergoing cervical spine operation.
खा लिया
Okay,
खाना खत्म करो अब फिर नमाज की तैयारी और फिर कुरान पाक भी पढ़ना है
please, my colleague, mute yourself. Accept the candidate in hot seat.
hello.
Candidate in hot seat, open your mic, please.
Yes, sir. I'm online, sir. How are you, sir?
Yeah, fine. Welcome. This
Yes,
is the
yes,
preoperative.
yes,
Okay,
yes,
this
sir.
is a
I've
preoperative.
been provided with
Yes.
I've been
Hello?
provided with sagittal. Sir, am I audible?
Yes. Yes.
Yes.
What happened here?
I've been provided with sagittal T2.
Yes.
Hello.
Yes, yes, I listen you well.
Yes, yes. I've been provided with sagittal T2 weighted images, uh,
Mm-hmm.
in which I can see um, hyperintense signal in the intramedullary aspect of the cervical cord, extending from C4 vertebral body to C6 vertebral body.
Yes.
And also, I can see there is diffuse disc bulge indenting the anterior thecal sac at the level of C5, C6 intervertebral disc level, which is causing
Yes.
compression of the cord at this level. And also, there is um, mm, compression of cord at this level, and resultant compressive myelopathy changes are seen.
Thank you. The patient underwent an cervical operation. Okay, and this is the post-operative MRI.
Okay.
What do you think? What do you
Okay.
think? Okay.
This is
Mm.
post-operative MRI. It shows there is there's a hyperintense area
Request
in
control, please. Doctor,
the
request control. Can you request control, please?
yes, sir. Um, 1 second. Uh, I'm not sure how to request. Uh,
No problem. I will scroll.
okay. So there is a large um, T2 hyperintense collection seen in the anterior, sorry, in the anterior epidural space with heterogeneously T2 hypointense areas. If we could scroll these, this is appearing to extend from the posterior at the site of surgical changes, most likely a post-operative uh, collection. I would also look at T1 images if there is any hyperintensity to rule out bleed, post-operative hematoma. Um, so
Yes,
can I have T
yes.
sagittal T1? Yes.
Sagittal T1. Okay.
So the collection is appearing to extend and the anterior dural space from the level of the lower cervical vertebral body levels, but there are no hyper intense areas within the collection to suggest if there is any hematoma. Um, so this is
Yes. Could you have a look here, please, and tell me what's happening?
yes,
What is the name of this sequence?
to GRE.
Excellent. What happened? By the way, this is the key of the
Okay,
answer.
there's blooming. Yes, blooming is noted in the GRE sequences. So then likely suggest of hemorrhage. So,
Okay, what else? Look well. Look well inside this collection and tell me why hemorrhage and collection occur like this. See the location. Is it logic? Is it logic to be very far from the site? The site of operation almost here. Why the collection and the hemorrhage and whatever? We don't know what it is. Occur here, almost far.
hmm.
What do you think?
5 minutes up.
Okay, give us 1 minute. Uh, you answer well. This may be collection with hemorrhage. What else? Look,
So,
what else? Patient, patient has no fever. Okay, he just has
okay,
some sort
okay.
of dysphagia, post-operative dysphagia. What else?
Oh, oh.
Look here.
Um,
The collection is nearly completely filled with this blooming artifact. Give me another differential, please.
so, another differential. So is it something related to prevertebral abscess or no?
No, I told
Or
you the
I'm not sure,
patient
sir.
just has dysphagia. What else?
Okay.
Collection
So
with
esophagus.
large amount of blooming artifact. It is something related to the surgery, by the way. If, what is the next step? The examiner told you, okay, your answer is good, but it is something else. He is helping you now.
Um, yes, sir.
What is your next step? Do
I'm
you want
afraid.
to do any other
My,
investigation?
sir, I would like to do is to look for any CT angiogram of neck to look
This
for
is the CT.
uh,
What do you think?
exorcism. Okay. Okay. Oh, there is okay hyperdense structure in the epidural space with
Yes. What diagnosis? Doctors, what it
uh,
is?
would like
What diagnosis?
sir.
What is this?
Gossipeboma.
Thank you. Thank you so much. And
So
this is,
gossipeboma.
yeah, excellent, excellent. And
Yes.
this is one possible case scenario. Okay, one possible case scenario. Thank you, doctor, so
Okay.
much. Let's take two or three
Yes.
advices.
Yes,
What
sir.
happened
Yes,
here?
sir.
This is the pre-operative. Okay. And I told you from the beginning, the patient has a complaint post-operative. So in 20 seconds, tell the examiner 2, 3, 4, 5, 6 posterior disc bulge or protrusion, compressing the cord, and with subsequent cord compressive myelopathy. Thank you. Like this. Why? Because the examiner had 5 minutes, and he wanted to show you this one, and to show you another thing. What happened here? You forget to
Mm.
tell me about the site of operation. This is disk spacer, my colleagues.
Mm.
And the disk spacer extended beyond the posterior surface of the vertebrae. And this is abnormal. Very important. Devices, lines, implant should see in T1. This is completely abnormal. Okay, posterior displacement. In my opinion, it is not mentioned here by my colleague, by the way. But in my opinion, this is abnormal. Why? If you notice, it's not possible for the disk spacer to compress or to touch the cord. Not possible. Anyway, look here. This is the myelography. This is the site of operation. This is the disk spacer. Okay. Then you did very well when you notice this collection. Okay, and extended to the disk spacer, but there are no vertebral end plate or anterior surface of the bone erosion. This is along the spine, the whole cervical spine. Besides that, I confirmed that the patient didn't have fever. The patient just has dysphagia. I know this is very, very atypical case. I know. Okay, but why? The examiner wanted to squeeze your knowledge.
Yes.
What happened here? Collection, post-operative,
Mm.
and the spine is completely normal. Patient didn't have fever, so spondylolischitis is out of our differential diagnosis. And the examiner trying to help you when he give you this one and insists this is large amount of blooming artifact. Okay. So gossypoma, especially in post-operative, keep in mind, especially in abdomen. I know most of you are expecting gossypoma in abdomen. Okay. Uh, but now the RCR examiners um, RCR examiners are as I noticed every time they bring very atypical cases and unfamiliar cases. So gossypoma confirmed by CT. At least we should tell the examiner, doctor, this is a typical collection with high density blooming artifact. I want to rule any calcification foreign body by X-ray. I think this is logic. X-ray or CT will show you this very characteristic spongiform collection with this radio opaque threads, which is very, very suggestive of postipoma. Thank you, doctor, so much. I know my colleague, it is very difficult case, but I'm trying to cover as much as possible
Yeah.
atypical cases. Thank you so much. Next candidate.
Yes. Thank you so much.
Good afternoon, sir.
The answer, cervical postipoma. Very important case. Next candidate.
Yes.
Doctor, this is 30-year-old female patient presented with right lower quadrant pain and increased inflammatory marker. Okay.
Yes, sir. Yes. Requesting controls.
Uh, okay. Go on.
Sir,
Go on.
cannot scroll.
Scrolling.
I have been provided with CT scan of the abdomen of a 30-year-old female presented with a right iliac fossa pain,
Mm-hmm.
where I'm seeing. I'd like to first scroll through the whole images before commenting. Coming back to the pathology. Going slow, sir. Some scrolling issues there, sir. So appendix. Appears normal.
An advice for you, try to talk even you didn't find any pathology. This is not acceptable, not good for you to keep, I think, about 2 minutes without any talks. Hello? Hello? Hello, Dr. Ali?
I can see that candidate 2 is with us, but I cannot hear anything also.
Yeah, candidate 2, candidate 3, and 3, can you listen us? Okay. Candidate 4, are you ready?
Yes, sir.
I will reset the timer.
Okay. Candidate 4, this is again 30-year-old female patient presented with right iliac fossa pain. Can you scroll?
Sir, I've requested.
One second, one second, one second.
Okay.
Go on.
Okay, so I've been provided with axial non-contrast CT scan, abdomen and pelvis in a 30-year-old female who has lower abdominal pain.
Yes.
So I'm scrolling down to the last cut. And so this is the last cut available. As I'm moving superiorly, I can see the bladder outline is preserved. The uterus appears normal in size. The adnexa do not show any gross enlargement within the confines of non-contrast CT. There is some prominence of vessels in the right iliac fossa. Other than that, I saw that the ileocecal junction is preserved. The appendix is normal in caliber. Right here. There is no evidence of acute appendicitis. I
What
will
else?
just go through the stack of images. See if there is anything in the upper abdomen which is concerning. So yes, this lung bases do not show any obvious abnormality. The solid organs in the upper abdomen appear to be preserved and outlined. I do not see any evidence of free air. However, I would also like to change the window to confirm that. I do not see any significant bowel loop dilatation as such, and there is some abnormality over here. I can see that the one of the bowel loop appears slightly thickened and angulated. Other than that, I am looking at the sigmoid colon. This also appears to be normal. So I would be concerned if there is a post-contrast image available, so I can further evaluate the pelvic organ, especially the adnexa.
Concentrate
we
in
have-
right iliac fossa again.
Okay, sir. So in the right iliac fossa, I will be concerned if there is any adnexal pathology, which I don't see. And other than that, sir, I am unable to identify any significant pathology other than the fact that the appendix goes up till here.
But the patient main concern about the right iliac fossa.
Okay. Right iliac fossa, ileocecal junction is normal. There are few bowel loops which are normal in caliber.
Leave the mouse.
Sorry.
Leave.
Yes, sir.
You want to post contrast?
Yes, sir.
Okay. This is the post contrast.
Okay. So in the post-contrast images, can I scroll? Yes. So in the post-contrast images, there is an abnormality in the right iliac fossa, which shows an internal hyperdensity as well. I'm trying to see if it is communicating with the bowel loops. So yes, it is. This likely represents terminal ileal loops, which are slightly equalled right here, this part. But I would also
Yes.
like to look if this is a blind ending structure or this is part of the terminal ileum, because I would be also concerned about possible Meckel's diverticulum with inflammation as well, because I think it ends here.
So
So, sir, I would also look at the coronal images for confirmation. Otherwise, I do not see any obvious signs of perforation. There is no free air. There
one
is no
second.
normal collection.
This is the coronal.
Okay, I can see on the coronal again. This structure is visible. I will try to
Yes.
scroll.
I think this is not scrollable.
Okay, okay. So if sir, this appears to be a
Time's up.
blind ending structure, since the appendix was normal, I
Thank
will be
you.
thinking of acute Meckel's diverticulitis. I will convey my findings to the referring physician and
Okay,
suggest
what
urgent
is the
surgical
underlying
intervention.
pathology? 1 second. What is the underlying pathology in Michaelis here?
Sir, I can see there is a hyperdense structure. So this could be some ingested material, some foreign body, or
So what's your
or
final diagnosis?
fecolith. Sir, Meckel's diverticulitis, acute Meckel's diverticulitis,
Due to?
due to possible foreign body or fecolith impaction.
Excellent, doctor. You did very well. Thank you so much.
Yes, sir.
Doctor, what's your
Thank you, sir.
name?
Serish.
Uh, you did very well, Dr. Sesh. Really, you did very well.
Thank you, sir.
What happened here, my colleague? This is another type of small finding, but very important. Why? It is a foreign body, not a foreign body is exactly. It is a fish bone perforated the Michaelis diverticulum. Okay? What happened here? I think the examiner will tell you a big history. Patient has abdominal pain. Why? Because during our daily work, the appendix, even in ultrasound or CT or MRI abdomen, should be augmented, either normal or abnormal. In some countries, appendix is represent 50% of acute abdominal causes. So you must have a look and comment about the right erectus. The non-contrast is the most important here. What happened here? There are some hyperdensity penetrating the bowel here. We don't know which bowel, but at least we pick up the beginning of the scenario. So we must follow this structure. Uh, as you know, the small bowel is too much confusing. I told you many times before. First, catch the ceca. This is the ceca. And how could you know? By the ileocecal junction. And how could you know the ileocecal junction? It is projecting inside and a little bit surrounded by fat. And this is the ileum. Okay? This is the ileum, this one. Is it clear? I will also use the annotation because this is very important. This, the green one, is the ileum. This one is the appendix. Okay? This one is the ileocecal junction. Very important. Okay? Follow them, please. Follow. Okay? At least we catch our normal anatomy. Then this structure we wanted to see. At the beginning, it is a blind ended. And it is not the appendix because we demarcate the appendix here. This is the appendix. This one. Okay? This is the appendix. So this is not the appendix, especially it is anterior. Second, we want to know the connection of this one, of this structure. Follow it. You must scroll up and down, where this is the structure. Okay? This one. Follow it, follow. Here, connected with something here, with this structure. So you must follow this one. Follow up. It is connected with the terminal area, with the distance, and about a few inches from the ileocecal junction. So it must be diverticulum. Which diverticulum here? Michaelis diverticulum, containing fish bone. Very important. At least if you exclude the appendicitis, it will be very easy for you because the other differential diagnosis, a pathology in Michaelis. And by the way, doctor, this is not diverticulitis. Why? If you look well, the wall of the Michaelis is not thickened. It has just some smudging fat here as a site of fish bone penetration outside the lumen. Is it clear? I think it is clear. Next candidate. Hello? Hello? Hello?
Hello?
Yeah, next candidate, Dr. Ali, please.
Yeah. Candidate 5, are you with us?
Yes, I'm here. I thought candidate number 3 is gonna have another go because I said he's back from the network disconnection. But yeah, I'm happy to go with this one.
Okay, go for it.
Okay.
30-year-old
so
male patient presented with right eye problem after head trauma.
okay. So these are axial images of T1 weighted scan post contrast in a 30 years old male patient with eye problems following trauma. The key finding here is marked expansion of the bones of the skull base as well as the frontal bones and the calivarial bones, more prominent on the right side. Can I take control or would you like to scroll for me?
Okay, take control.
Okay, so yeah. These are T1 weighted images in post-contrast T1 weighted images. I can see as I said before, marked expansion of the bones of the calvarium over the right frontal bone more than the left. It extends to include the temporal bone and the greater wing of the sphenoid on both sides. It causes complete obliteration of the ethmoidal sinuses, the nasal cavity. However, the maxillary sinuses are spared, partially spared. The nasal cavity is clear at the inferior part of it, so the inferior nasal turbinates are well visualized. However, the middle and superior nasal turbinates are included in this expansile lesion. It shows intermediate to high T2 signal intensity with areas of I'm sorry, this is not T2, intermediate to high T1 signal intensity and some areas of high of contrast uptake. I can't really identify the optic canal or the orbit. It feels like the bony expansion has obliterated the optic canal on both sides. I wonder if this is the reason for the patient's. I can see, yes, the optic canal on the left side is barely visible, and also on the right side here. There is marked narrowing of the optic canal on both sides. So my primary diagnosis based on these sequences is going to be a fibrous dysplasia, giving the patient is young age, young adult, and it's mainly a bone process. I couldn't see any enhancing soft tissue component to it, so it's mainly a bone disease. I would like to assess other projections like coronal projection to see if there is to better analyze the compression on the optic nerves on both sides. Yeah, the sagittal beam here. Yeah.
See here.
Yeah, on T2, there are cystic areas which might represent the lytic and sclerotic changes that happen with the bone, changes in fibrous dysplasia. It causes compression also over the frontal lobe, and there is evidence of bilateral maxillary sinusitis, probably because of occlusion of the osteomeatal complex and the drainage of paranasal sinuses. It also encroaches on the base of the skull at the level of the pituitary gland. So it's probably also compressing the optic chiasm. So I can't see any evidence of bone fracture. This is better assessed, of course, on T1 weighted images, but also here in T2, I can't see any features of
What is
bone
your
fracture.
final diagnosis, doctor? Final diagnosis,
Yeah,
please.
in summary, this is skull base fibrous dysplasia. I would like to send the patient for ophthalmology assessment to assess the optic the visual changes due to compression on the skull base foramina, and also for neurological assessment for other cranial nerve compression. I'd also like to see other skeletal X-ray films of other parts of the body to see if it is polyostotic. I would be concerned about other syndromic associations such as Mackin-Albright syndrome, if it is
What is the name
polyostotic.
of this appearance, doctor?
I can't remember the exact name for this appearance. I'm sorry. I think Lionitis facies. I'm not sure if it happens with fibrous dysplasia or Paget's.
Lenontesia ossea, as I think, which
Yeah,
means the lion face. Okay.
lion face. Yeah, something.
Yeah, lion face. Okay.
Time's up.
Thank you, doctor. Thank you, doctor, so much. Doctor, what happened for the optic nerves? Because I lost you in the middle. Did you
There's
comment
narrowing.
on?
Yeah,
Yes.
I did comment on the narrowing of the optic canal on both sides.
One of the most, thank you, doctor. This is a case of uh, maxillofacial or involving the skull, even the skull, because it is involved most of the maxilla and facial bone fibers dysplasia. What happened here? I gave hair post contrast, okay, to simulate infiltrating mass, but she was wise enough to get the answer. What happened here? Um, large expansile mass or large expansion of the diploic space and the bones, affecting mainly the face and the frontal bones. The best to be revised here, X-ray, very important. And then she asked for skeletal survey, and she wanted to exclude Macon-Albright syndrome. Very great. Here also it is slightly compressing the brain, especially the frontal. Okay, slightly, but not obvious really. Here, slightly. The most important to exclude cranial nerve compression. Here, see, it causes a little bit compression here, but it is compressing, narrowing post-optic nerve. If you see here, there are dilatation of the pre-optic CSF space. This is a sign of compression. Thank you, doctor, so much. It was a craniofacial fibrous dysplasia. Don't forget in MRI, especially in MRI head and neck. Candidate, the next candidate.
Hello, sir.
Hello.
This is
Yes.
candidate 6.
Yeah, 35-year-old female patient presented with cough.
Okay, so this is the frontal chest radiograph of 35-year-old female who has presented with cough. I can see there is the right hilum appears dense and enlarged. And looking at the right bronchus, I think there is some opacity which is projecting over the right main bronchus as well. The rest of the visualized lungs are clear. I don't see any evidence of other mediastinal lymph nodes, no cardiac enlargement, no evidence of pneumothorax or pneumomediastinum, no pleural effusion, and the visualized bones appear unremarkable. So to conclude my finding, the right hilum is dense and appears enlarged, and my differential for this appearance could be a right hilar mass. So in my routine practice, I need to confirm this with CT thorax and any previous imaging if available for this patient. Okay, these are the lung windows of the CT thorax of the same patient. I've just scrolled through the images. And sorry. Okay. Okay, in the visualized images, all right. So I think there is a mass which is present in the right hilum, and also it is projecting it to the right main bronchus as well, with some endobronchial element as well over here. And so yeah, I will confirm it on the soft tissues windows as well. I don't see any evidence of other intrapulmonary nodules on either side. No pleural effusion is noted. I will see. I will like to confirm it on the post contrast images in the soft tissue, and my differential for this appearance is a endobronchial carcinite, which should be enhancing on the post contrast images. And if this is my provisional diagnosis, to take it further, I would like to also confirm it, convey the findings to the referring team. To the this patient should be urgently sent on 2-week wait to the lung MDT and discussion regarding nuclear imaging for confirmation of this scan, like DOTA PET CT should be considered.
Okay, doctor, but do you think the carcinoid is malignant, benign, local malignant?
Sorry?
According to carcinoid, your differential were carcinoid. Okay.
Yeah, my differential is a carcinite or and also intrinsic lung mass with endobronchial extension. as well.
Which
That is a
one,
possibility.
which one you will put in your first differential, carcinoid or other lung mass?
I think the carcinoid would be my
Why?
first differential
Why?
because
Why?
of the endobronchial extension, endobronchial component of
What
this
else?
mass.
What else?
And also it is, let me just have a look on this post contrast.
Did you remember the age of the patient and sex of patient?
The patient is 35.
Yeah, female 35. So all of
Yeah,
these are
35 female.
So is it
Okay,
lung
so
mass or carcinoid?
I think carcinoid is more common in young age than lung mass. That is, but lung mass is a possibility as well, but carcinoid would be my top differential. And it needs further evaluation discussion in lung MDT and endobronchial biopsy consideration, and PET-CT, daughter rate PET would be considered.
So because it is female, non-smoker, adult, not elder, carcinoid, should be in the first of our differential diagnosis. And how can I know it is a smoker or not? From the lung window, no central lobular, almost no central lobular emphysema, especially at both lung levels. This
Yeah,
patient, if the clinician insists to do some sort of biopsy, what is the most suitable route?
I think endobronchial
Excellent. Thank you, doctor.
biopsy.
Really,
Yeah,
thank you so much.
yeah,
So
endobronchial.
it was a carcinoid. Take care, my colleagues, from two signs. Most of us missed it, even in daily work. Dense hilum sign. And another one, the losing, this is another entity, but just by the way, losing of more dark sign here in the lateral. Very
Yeah,
important. Very important. Signs, most of us lose it. Okay, take care. Finally, it
thank you.
was dense hilum sign due to carcinoid. Thank you
Carcinoid.
so much. Thank you so much. Next and last candidate. Yes, doctor, request control. Request control. Hello? Hello?
Hello, sir. Assalamu alaikum.
Alaikum salam. Request control, please. Doctor, this is 14-year-old male patient presented to you. 1 second, leave the mouse. Leave the mouse. Leave, please. Presented to you. He come brought by the ambulance, fainted from the street. Go on.
This is axial MRI brain T1 weighted
1
image
second.
of a 14.
1 second, please. Leave the mouse. Go on, doctor.
Okay. This is axial T1 weighted MRI brain image of a 14-year-old patient who has brought from street unconscious, in which I can see that there is T1 hyperintense fluid opacification of mastoidal cells bilaterally. Coming up, I can see that there is T1 hyperintense signal in right parapharynx location in the region of body of corpus callosum and in the splenium as well. Considering the history of trauma, my first differential in this case would be hemorrhagic fluid, and I will correlate it with other images to look for any other areas of hemorrhages and mass effect. In this case, I can see there is also T1 hyperintense signals along pharynx. There is no midline shift, no mass effect, no ventricular dilatation, and further going down here, you can see that there is no fluid collection or and near vertex only the Fox is hyperdense. So I will correlate it with susceptibility weighted imaging as well and flare images.
This is flare images. Go on.
This is axial flare sequence in which I can see that in midline, in the region of Fox, there are centrally hyperintense and peripherally signal void hemosiderin rim containing areas, which are a larger area on right side with surrounding edema and a similar smaller lesion on left side of midline. Okay, so considering this appearance, I will further add the differentials of any cavernoma with acute hemorrhage and surrounding edema. And there's associated sulcal effacement as well. In the right temporal horn of lateral ventricle, again, there is a focus of hemorrhage here. And considering the presence of fluid in mastroidal cells, I will correlate it with CT scan findings to exclude underlying fractures in skull base. And in the extraaxial regions, no definite hemorrhage in extraaxial space. And I will also have a look on the susceptibility weighted images. Yes, I can also see that there are subcortical areas of hyperintensities and in left frontal and left parietal lobe and in right frontal region as well. If there are multiple areas of microhemorrhages in these regions as well, then I will, and the patient is comatose. Yes, sir. And the patient is comatose, then I will also keep differential of diffuse axonal injury.
What's your final diagnosis?
Sir, considering predominant corpus callosum involvement and the patient has history of trauma, so in that case, my first differential will be diffuse axonal injury. But if the patient was found unconscious without any history of trauma, then it can be a cavernoma with acute hemorrhage in it.
Okay, in your opinion, this is what's the most likely? 14-year-old found comatose in the street. And
Without
the MRI.
Okay, found comatose in the street and you did MRI, then it will be first cavernoma with acute hemorrhage.
Cavernoma, okay. If this diffuse axonal injury, which degree?
So then it is involving, there are multiple signal void areas in the, yes, there's no involvement of brainstem. So it will be grade 1.
No, see, I'm talking about this patient. So, so give me a degree of this patient.
Okay, on SWI images, I can see, yes. I can see that there are no blooming in the brainstem and
Look again, please.
in the
Stop
cerebellum.
here.
Yes.
No. Stop at the tactile plate.
Okay.
What is this in
Yes,
the
sir.
tactile
There is
plate?
a small focus of, yes, there's a small
Yes.
focus of
Okay.
blooming in the tactile plate, yes. So it's grade 3.
Okay. In my opinion, thank you so much. In my opinion, Dr. Cavernoma will be more random. But look here. First of all, there are, I think, some collection here, as I notice. Maybe some collection. Okay. Otherwise, if you have a look, generally, the blooming artifact occupying a very specific location. Number one, corticomedullary or white gray matter locations. Okay. Number two, corpus callosum. Okay, corpus callosum. Number three, and very faint here and here. See, do you think the cavernoma will have this very, very characteristic location? Cavernoma usually random. Are you agree with me, doctor?
Yes.
Okay. So in 14-year-old, bring patient brought from the street, okay, and he is comatose, keep axonal injury, or at least tell the examiner, doctor, I will ask, I will search, I will see, examine the patient for any signs of trauma. Why? Any traumatized patient, you should see something physically, by clinical examination in his face, fracture in one arm, signs of struggling, like this. Because at the end, we are clinician, not only radiologist. So the final answer of this patient is diffuse axonal injury, grade 3. Thank you, doctor, so much. Thank you, Dr. Ali. Study hard, my colleagues. It is about less than 20 days for not far from the exam. Thank you. Thank you, sir. Goodbye.